Assalamu alaikum wa rahmatullahi wa barakatuh. We will continue the second part of the lecture and we will start with cervical cerclage, which is one of the important measures of prevention of preterm labor. When we should do cervical cerclage, it should be done to a woman with cervical incompetence. And what we mean by cervical incompetence? We mean that the cervix is weak and unable to remain closed during the pregnancy. The cerclage will provide a degree of structural support to the weak cervix and also has a role which is very important in maintaining the cervical length and the endocervical mucus plug as a mechanical barrier to ascending infection. This picture shows a woman with cervix, which is a normal length of the cervix. This is the internal and this is the external os. And this is another woman with short cervix. When the cervix becomes short, it will be weak. And this may lead to either preterm labor or preterm. This is pictures which shows how the cervix will have shortening of it. This is a normally closed cervix. This is the internal, the external os, and normal cervical length. Then here, there will be shortening of the cervix with dilatation of the os. There will be funneling. Here, the shortening is more until here the internal and external os will be close to each other. And this is diagnosed with transvaginal ultrasound. This is the first picture with the T-shaped cervix. And here, when the cervix starts to have shortening, and it is more short, and this is the U shape. When we should do cervical cerclage, we say that when the patient have a diagnosis of cervical incompetence. How can we diagnose the patient as having cervical incompetence? Either by history. When the patient have history of 3 or more spontaneous preterm labor or second trimester miscarriage, we will insert the cerclage for her between 12 or 14 weeks of gestation. It will depend here on the history. Either 3 or more preterm labor or 3 or more second trimester miscarriage, because cervical incompetence may lead also to second trimester miscarriage. The second indication is the ultrasound indicated cerclage. Here the woman will have a history of 1 or more preterm labor or second trimester miscarriage. And because she has this history, we will do serial measures of the cervical length to screen for the cervical incompetence between 14 and 24 weeks of gestation. And if the length of the cervix is less than 25 millimeters, we will perform cerclage for her. The third cause of, indication for cervical cerclage is the rescue cerclage, which is done usually between 16 and 28 weeks gestation. Here the woman will have symptoms of preterm labor or threatened miscarriage, and after that, this pain will lead to cervical dilatation and shortening. So if the woman has symptoms and these symptoms are minor and subside, but they lead to cervical shortening or dilatation, so we can perform a rescue cerclage to these women. So the cerclage here is a therapeutic measure. What are the types of cerclage? A cerclage can be inserted either by transvaginal approach or by transabdominal approach. The usual method is the transvaginal approach, and the most common one is the McDonald cerclage. We will do it. All the types of cerclage should be done under general anesthesia. The McDonald is inserted at the level of the cervicovaginal junction. The second type of cerclage is the Schrute-Carr cerclage. which is the high transvaginal cerclage. It is inserted above the level of the cardinal ligament. And here we need to mobilize the bladder and to do an incision in the cervix, and we will embed the suture in the cervical tissue. So it should be removed under anesthesia. The third type of cerclage, which is done by transabdominal approach, and the cerclage will be at the level nearly to the internal os, and this is done either in patient with history of recurrent failure of transvaginal cerclage, or when she have very short cervix, for example, patient with cervical surgery, with congenital anomaly of the cervix that lead to a very short cervix that the cerclage cannot be applied transvaginally. So we will do the transabdominal one, and it can be done by laparoscopy or laparotomy, and the timing of it either preconceptionally or during a pregnancy. This is the picture of McDonald cerclage. We insert the suture material here at 12 o'clock, then 9 o'clock, 6, 3 o'clock, and then we ligate it. The suture of choice for patients with to do cervical cerclage is the Mercerin tape suture, but it contains 2 needles, but it's not available always. So if it's not available, we can use the alternative one, which is the silk. We need a non-absorbable one because it should be removed later in the later in gestation at about 37 weeks of gestation, if the patient will deliver vaginally. But if she will deliver by cesarean section, so we should remove it at time of cesarean section. The Schroeder suture, as I told you, should be removed under the effect of anesthesia because it's painful. All women with the transabdominal cerclage require delivery by cesarean section, and the cerclage can be left in place following the delivery. In patients who have cerclage and complicated by preterm between 24 and 34 weeks of gestation, and there is no evidence of active preterm labor or signs of infection, we can delay the removal of cerclage for 48 hours to provide a course of prophylactic steroids for fetal lung maturity or for transfer to a center or hospital with a neonatal care unit. What are the contraindications for the applying of cerclage? First, patient with active preterm labor, when the woman have intrauterine fetal death, or she is carrying a fetus with liver congenital anomaly, if there is evidence of fetal compromise, if the patient have antepartum hemorrhage, or there is signs of chorioamnionitis. These are the contraindication of cerclage. And if the patient have cerclage and complicated by any one of these points, we should remove the cerclage. What are the complications of the procedure? There may be bladder injury in case of Schroeder, especially in this type of cerclage. Cervical trauma may occur, bleeding from the cervix, and sometimes rupture of membrane, especially when we apply the rescue cerclage. How can we manage a patient who have preterm labor? She presented to us with symptoms of abdominal pain. We first should put a differential diagnosis to this pain, because not all women who presented with abdominal pain during a pregnancy, that means she's in labor. There are obstetrical and non-obstetrical causes for abdominal pain, and we will discuss it in the meeting. How can we diagnose preterm labor? First of all, we take history from the patient about her pain, the severity of it, the frequency of the pain, and the time the patient has contraction. We will ask her about the duration of the pain. It lasts for example, a few seconds, for 30 seconds or more. And we will ask her also if there is any associated symptoms, for example, leaking liquor, vaginal bleeding. We will ask her about fetal movement, and also if there is any other medical diseases she may have. Then we will do examination for the woman. General examination is very important. The vital signs of the woman should be measured, and we will do abdominal examination manually first. We can count the contraction by applying our hand, put our hand on the abdomen, on the fundus, and we will count the contraction, the numbers, and the duration of each contraction. If this is difficult, we can do CTG. By the CTG, we can know the number of the contraction and the amplitude of each one. And also we will assess the fetus by CTG. Then we will do vaginal examination to know if there is any cervical dilatation and the status of membrane. The investigations that are important, for example, for patient if she has abdominal pain but there is no cervical dilatation, we can do fetal fibronectin test. If it is positive, or if her cervical length is less than 10 millimeter, or the dilatation is more than 3 cm, this means that the patient may have labor within the next 7 days. If the patient diagnosed with a preterm labor, what we will do for her? First, the patient should be admitted to the hospital. The support is very important because the patient will be afraid if she delivered a preterm baby because of the complications of a prematurity on him. We will start to give her steroid. Steroid is very important. Even if the patient in active labor, we should administer steroid because it will decrease the incidence of intraventricular hemorrhage, the respiratory distress syndrome, and the incidence of neonatal death. If the patient takes steroid and her pregnancy extended for up to 7 days, she will take the maximum benefit of steroid. So sometimes we administer tocolytics at time of giving steroid to prolong the pregnancy for at least 1 to 2 days, so the steroid will have a time to exert its effect. It should be not administered to gestations below 24 weeks, and we should give it until the 36th week of gestation. Here in Iraq, we give it even below 37 weeks of gestation, and if the woman have elective cesarean section below 39 weeks, we should give her steroids. The doses and the route is by intramuscular injection. We have 2 types of steroids, the betamethasone and the dexamethasone. The betamethasone is more potent than the dexamethasone. We give it in 2 doses, 24 hours apart, and the dose is 12 milligrams. While the dexamethasone, we should give her 4 doses, 12 hours apart, and the dose is 6 milligrams. The other measures of treatment of patient with a preterm labor is the administration of tocolytics. The indications of tocolytics: first, if the patient have very preterm labor, an extreme preterm birth, we can administer tocolytics, hoping for stopping the pain. But in patients who have moderate preterm labor or late preterm labor, the indication of tocolytics is first if we need to transfer the woman to another hospital. For example, if we are in the periphery and we don't have a neonatal care unit, we need to transfer to hospital with a neonatal care unit, so we need time. So the administration of tocolytics may give us time to prolongation of pregnancy. And also, we give it to women if we need to give her steroids. Any contraindication to prolongation of pregnancy is contraindication for administration of tocolytics. For example, intrauterine infection, severe preeclampsia, or patients with antepartum hemorrhage. What are the tocolytics that available? There are the beta agonists, the calcium channel blockers, oxytocin antagonist, and the COX inhibitor. The beta agonist nowadays is not used for tocolytic purposes because there is high risk of complication from this drug, and many women have arrhythmia, and in England, for example, they reported even death because of it, so they stop using it. The most common drugs that are used, either the atosiban or the nifedipine. They showed that it delayed the delivery up to 7 days, and both of them will decrease the incidence of perinatal mortality. Here in Iraq, we don't have atosiban, just nifedipine, so it is the commonest drug that is used. Also, we can use the indomethacin, which is a COX inhibitor, but it should not be used for more than 7 weeks because of the increase in the incidence of premature closure of ductus arteriosus, and it should be used also in gestations, usually below 32 weeks. We should avoid using more than one tocolytic in combination, as it increases the risk of adverse effect. What is the role of magnesium sulfate in women with preterm labor? The American College of Obstetricians and Gynecologists use magnesium sulfate as one of the tocolytic drugs. And also, the American College with the Royal College, they use it for another indication, which is decrease the incidence of cerebral palsy in women who have delivery below 32 weeks of gestation. So we should give it in women with PPROM or having a planned preterm birth within 24 hours by intravenous administration. The other measure of treatment is the emergency cerclage. If the woman in the mid-trimester with minor symptoms and have dilatation and bulging of membrane in the vagina, we should administer emergency cerclage. The fetal assessment is very important by intermittent fetal heart monitoring, either by using the handheld Doppler or by the CTG. In utero transfer to a unit with adequate neonatal facilities is recommended where these are not available in the admitting unit. The mode of delivery of a woman presented with a preterm labor will depend first on the gestational age of the fetus and the fetal condition, whether there is fetal distress or not, and depends on her obstetrical history. I hope the lecture is clear for you, and thank you for your listening.